Good morning. Thank you very much for joining us as part of this excellent production by mmlearn.org on innovations of chronic pain management. My name is Alexander Peralta. I'm a diplomat of the American Board of Hospice and Palliative Medicine. I'm an internist by training and certified and recertified in hospice and palliative medicine. The area of chronic pain and pain management has been something in my life for many years. I've had the privilege of taking care of many patients with chronic pain and acute pain. And so this presentation will actually be a touchstone of basic, intermediate, and advanced information on pain management, with a specific focus on chronic pain management. Our objectives are to describe national guidelines to define pharmacological basis of the use of opiates and other pain medications, define major categories of pain, provide non-opiate medications for different types of neuropathic and inflammatory pain, and also to discuss ethical imperatives and the challenges that are facing us regarding adequate pain control with patients with acute and chronic disease and the chronic pain associated with that. When we look at chronic pain management, we really look at the major tenets that were talked about a long time ago by Dame Cicely Saunders, who started the hospice movement that's moved on to the palliative care movement. I'll provide you with a definition of palliative care and palliative medicine, which I think is very, very important part now in the mainstream of medicine, because we are the people that actually will be taking care of patients between a gap between acute care and home care. And so the certification in this particular subspecialty, which 10 boards offer from the American Medical Specialties, we have the opportunity to have a lot of physicians familiar with this topic and also familiar with the care of patients that have pain, specifically physical, psychological, social, and spiritual pain. One of the things that Dame Cicely Saunders taught us, and the word she taught us, is total pain. Our Bayek talks about the fact that, there's a fragmentation of personhood and the challenges of meaning also that were brought out by Eric Cassell in his wonderful book and his article in New England Journal of Medicine back in 1982 on the nature of suffering. Now, when we look at the definition of palliative care, it's to seek to prevent and relieve and reduce and soothe symptoms of disease and disorders without affecting a cure. This is very, very important, looking at patients, because candidly, we cure very few diseases. But we palliate symptoms, and we do prevention and education to prevent some of these illnesses and chronic diseases. So palliative care in a very broad sense is not restricted to end-of-life care or hospice care. It's looking at how patients suffer with certain symptoms and how we can palliate them to improve their care. So the overarching goals, and as far as definitions of palliative care, is to prevent and relieve suffering and to support the best possible quality of life for patients and their families, regardless of the stage of the disease and other needed therapies, so they can be receiving acute care and still get palliative care. Palliative care is both a philosophy of care and an organized, highly structured system of delivering that care. Palliative care expands the traditional disease model treatment to include goals of enhancing quality of life for the patient and the family, optimizing function, which I think is pivotal, helping with the decision-making process, and providing opportunities for personal growth. I think that's very important, the opportunity for personal growth, whether it occurs in a minute, in an hour, in a day, in a week, in a month, in a year. It's very, very important for that oneness to occur for patients with particular types of diseases, especially chronic disease and life-limiting diseases. The program that really helped us to give a great start to palliative medicine and hospice care was the National Consensus Project on Quality Palliative Care, which really, from their executive summary and the third update, tells us a little bit about domains and quality of palliative care. So they created these domains of structure, physical aspect, psychological and psychiatric aspect, social aspect, spiritual, religious, and existential aspects of care, cultural aspects of care, and care for the imminently dying, and ethical and legal aspects of care. My focus will be today on the physical aspects of care, but I have enjoyed working with the cultural aspects of care. I have developed signs and symptoms of impending death, and of course the ethical aspect of care, which I'll mention briefly in this presentation. When we are addressing pain management, that falls under the physical aspect of care. These guidelines and criteria provide us with very, very important information. So there's an evidence-based way of approaching this in a very methodical way in caring for patients with pain. First of all, addressing it from an interdisciplinary approach. One person cannot manage someone with chronic pain over a long continuum. So subsequently, longitudinally, patients need to have a team that will help them to manage their pain. So the interdisciplinary approach of a social worker, a chaplain, a pain specialist, a nurse, and other people involved in their care is pivotal. So regular ongoing assessment of pain, you don't just go ahead and give medications and walk away. We need to make serially assess to make sure that we're taking care of the pain, and really to include symptoms associated with the pain, whether it be nausea or vomiting, shortness of breath, the weakness, the anorexia, the insomnia, that we will address. Because what we're hoping to do is we're looking at these symptoms to drill down into the neurobiology and the biobehavioral situations that occur from chronic pain management. The outcomes of pain and symptom management, whether it's safe and timely, was the right dose given at the right time and the right frequency for the patient. Respond to symptom distress, what's happening to the patient, and so we can track their pain and their symptoms and document it appropriately. The barriers to effective pain management, people are afraid, well, if you give my dad hydromorphone or do you give them morphine, they're going to become addicted, or are you trying to kill patients? Absolutely not. And we'll talk about the syndromes that are associated with chronic pain, but also the principle of double effect that tells us that our intent is to relieve suffering. The risk management and a plan to make sure that we make sure that there's appropriate outcomes, and risk management we'll talk also at the end with the federal and DEA guidelines that will be coming in the future that are called REMS. Patient understanding of the disease and its consequences. I think it's very, very important for patients to know what is happening to me. Why am I having these discomforts? Why am I having these symptoms? What can I do about them? Is this a very important sentinel marker for me in my life? And then family also understanding the disease and its consequences. Then treating distressing symptoms and side effects with whatever medication or whatever syndromes that they have, or whatever situations they may be having at this particular time, because there's a lot of external factors that affect pain management, and specifically chronic pain management. Pain is due to disease, and this is part of my upcoming book that I will focus on these three major sentinel markers or tenets regarding acute disease and chronic diseases. Pain, whether it's psychological, social, spiritual, or emotional, loneliness, and the religious and existential issues that it brings, and also loss of control. This is a very major issue to a lot of patients. Loss of, which speaks to ethical issues, our final disengagement, but more importantly, loss of autonomy, loss of the things that we're able to do that we can no longer do because of our disease process. Now, when we look at patients that are at risk for pain, we always look at pain from a cancer perspective. Cancer was the sentinel marker for all of us to learn about all the different neurobiology, the neurocircuitry that had to do with pain management. So we've extrapolated that information that we've learned from cancer patients, both adults and children, into non-cancer illnesses. Patients with dementia, and cardiac disease, and pulmonary disease, neurological types of syndromes and diseases, end-stage organ disease, end-stage liver and kidney and other types of diseases. And then, of course, patients with AIDS. Osteoarthritis, rheumatoid arthritis, vertebral compression fractures, and other syndromes that people may have due to chronic illness or osteoporosis. And then congenital anomalies, having done pediatrics for 10 years, are some of the symptoms we see for children, the trisomies, the spinal muscular atrophies and the different types, the lipodystrophies, leukodystrophies, and of course sickle cell. Sickle cell is where I've learned how to take care of chronic pain management over the years. This is where I learned how to manage people appropriately during the 2 times of the year when the sicklers have crisis, which is usually in early spring and late fall. When we look at the pharmacology of opiates, we look at how opiates work. We look at how they actually are in the system and how they work in certain types of receptors. So this is receptor site theory, looks at how medications and also endogenous substances like beta-endorphins, dynorphins, and met and enkephalins work in our body to help relieve pain. We have the receptor site theory talks about having receptors that are agonist pure agonists, which is really how drugs work. The most potent pure agonists, of course, are endorphins and dynorphins and encephalins. But there are drugs, very much like morphine and hydromorphine and fentanyl, that tie very well or lock very well with different receptors, and we'll talk about those in a minute. And then there's partial agonists that have an effect, but that's not maximal. The intensity of the pain is relieved, but not totally. Then we have antagonists. These are drugs that actually are given to counteract. They're competitive type of drugs that compete with a particular receptor and inhibit the action of that particular receptor. And I'll give you some examples of that, where they could be pure antagonist and also partial antagonist. Now, the most common receptor that we see in the area of pain management is the mu receptor. And its effects are analgesia, which is the most robust receptor we have. May cause respiratory depression, and that's an effect on the carbon dioxide receptors in the medulla. Inhibition of gastrointestinal tract, so it affects the Auerbach axis in the colon, and of course causes constipation. And then euphoria, which is an effect that it has on the limbic system. Euphoria is something that's very interesting because many times people think, oh my God, the patient is euphoric, so they must be addicted to a drug. No. That's just part of the pharmacological property of the drug, just like constipation, just like sometimes when we see respiratory depression, and of course the analgesic effect they get in the midbrain and spinal cord. Then there's kappa receptors. Once again, they're also very good analgesics, and I'll give you examples of some of these in just a minute. They work in the spinal cord. There's actually kappa 1, 2, and 3. They work in different areas of the central nervous system. And then the GI motility, it causes constipation, but it also causes diuresis because it has an effect on the pituitary gland. The last receptor is the delta receptor, and these are the traditional receptors that we're familiar with, and I'll talk about more receptors as we continue with this presentation. This is a minor type of analgesic, once again working on the spinal cord, usually on the brain and the spinal cord. It develops tolerance. We don't know how exactly that works, but we know that can occur. The most common type of delta receptor we know is methadone, and we'll talk a little bit about not only working on the delta receptor, but also the mu receptor and another receptor we call the N-methyl D-aspartate ion complex antagonist. And then, of course, the possibility of seizures, okay, with some of these drugs, and having an effect on the cortex of the brain, and subsequently causing seizures. That's also how a certain metabolite like normeperidine, which is a metabolite of Demerol, causes seizures in patients. You have to be very careful with Demerol. Demerol certainly is not the drug of choice for acute or chronic pain management. That is morphine. So therefore, when you look at these receptors and we look at where they work as far as the pharmacokinetics and pharmacodynamics of these receptors and understanding the pharmacology, we come to the major analgesic drugs that we use on a day-to-day basis, which is fentanyl, morphine, oxycodone, hydromorphone, and tramadol. Tramadol also has an effect on the mu receptor. This receptor affinity little guideline here, this little table, talks about where certain drugs work, like morphine working on the mu receptor, and fentanyl, and hydromorphone, and oxycodone working not only on the mu receptor, but the kappa receptor, methadone working on the mu receptor, the the delta receptor, and then the N-methyl D-aspartate antagonist. We look at other drugs like ketamine, and we also look at dextromethorphan. Dextromethorphan is the DM portion of Robitussin. All of us have taken probably some Robitussin DM in our lifetime. And you notice that in most of the cold preparations, now the only drug that's available in these preparations for cold and for sinus congestion and things of that sort is dextromethorphan. Dextromethorphan is the optical isomer of methadone. Okay, in methadone, we have a racemic mixture of both D-methadone and L-methadone. D-methadone is a very potent antitussive. L-methadone is a very potent analgesic. So when we look at other receptors, we look at the N-methyl D-aspartate antagonists or inhibitors, we look at a particular group of drugs that affect the blockade of amino acid, specifically glutamate, from building into the certain types of N-methyl D-aspartate receptors, reducing depolarization in certain neural spinal cord neurons. This continued firing of these neurons causes hyperalgesia, and this hyperalgesia causes a wind-up phenomenon that promulgates pain. And the most important thing I want to leave you with in pain management is to break the pain cycle, whether it's acute pain or chronic pain, to give the right drug at the right time and the right frequency and at the right dose to break that pain cycle. And I'll explain to you later on why that is such a very, very important. So what is the definition of pain? Pain is an unpleasant sensory and emotional experience associated with actual and potential tissue damage described in terms of such damage. That's the definition by the International Association in the Study of Pain. But pain is what the patient tells you it is. They're going to tell you they hurt. They may not tell you they have pain. I have an ache. I have a soreness. I have discomfort. I don't feel well. When I do this, I get this symptoms. I get nauseated and things of that sort. They may not say it's pain. So we have to kind of more or less do some investigative type of work to find out what they're trying to describe. And sometimes they're nonverbal observations of pain as well. Acute pain. Everybody knows what that is. That's what brings you to your knees. That's a typical heart attack, the Levine sign, the heaviness in your chest, the shortness of breath, the ashen look, and the pain radiating to your left side, which is a combination of different types of pain, which I describe as complex pain syndrome. Then you have chronic pain, which we see very commonly in cancer pain. This may be acute, may be chronic, may be intermittent, and usually has a definable source, which is usually the cancer or the metastasis of the cancer to other organs. Then you have chronic pain, and this is where I've lived for the last 30 years. The privilege of caring for patients with chronic pain. You know, it's very difficult because they don't have signs and symptoms. As I mentioned earlier, I took care of patients with sickle cell disease. I saw that many of these patients had acute pain, but they also had chronic pain. And only the acute pain was treated when they actually had pain so severe because they were sickling and they had to go to the emergency room. They were not looking for drugs. So managing their chronic pain is pivotal in managing their acute pain as well. If we don't manage their chronic pain appropriately, then you get some of these symptoms of anxiety, hostility, loneliness, depression, insomnia, anorexia, frustration, anger, and suicidal ideations. Now, we have seen some of these symptoms. We know some of these symptoms. They're very high profile in the news today, that people are in despair, a sense of hopelessness because of their disease, or a sense of hopelessness because of their severe substance abuse or chronic depression. The major categories of pain is nociceptive pain, neuropathic pain, and inflammatory pain. Nociceptive pain is a stimulation of the nervous system, peripheral afferent fibers that come from a variety of different sources to the dorsal horn, sending information to the cortex of the brain through the spinal thalamic, spinal reticular, and spinal hypothalamic tracts, so that pain then is realized, and of course it can be manifested as somatic pain, aching, constant, localized, musculoskeletal type of pain. It can be manifested as visceral pain, sharp, crescendo, decrescendo pain that we see with angina, also with acute cholecystitis, renal stones, and of course bowel obstruction or a myocardial infarction. In a myocardial infarction, you see this very complex picture of someone having nociceptive pain, which is the pain that we describe as the heaviness, the shortness of breath, due to visceral involvement of the heart and the lungs. And then you also have this next component, which we call neuropathic pain, the numbness and tingling sensation because of stimulation in the brachial plexus that causes the numbness, tingling, and burning sensation to that particular arm. So therefore, neuropathic pain, it can be ischemic, destruction of nerves, encroachment of the nerve by a tumor, and other sources, inflammatory sources that can cause this paroxysmal type of shooting shock-like pain in a background of burning and aching sensation. Inflammatory pain. Response tissue that potentiates pain. This is inflammatory pain. Most of the diseases we care for on a day-to-day basis are inflammatory diseases. So the inflammatory factors play a very, very important role. We'll talk about some of the catabolic cytokinins and inflammatory cytokinins in our second part. So the pro-inflammatory factors move from a peripheral aspect to a centralization. And there's also this thing about phenotypic switch. We'll talk a little bit at the end of this presentation on neuroplasticity. A phenotypic switch basically says that the neurobiology of the brain and its nervous system has changed. And therefore, drugs that you had used before, like Neurontin, no longer work because there's been a major change. A very acute example of this is people with peripheral neuropathy, or painful peripheral neuropathy due to diabetes. You can give all the medications you want to for this severe, painful peripheral neuropathy. that if you don't manage their blood sugars, if their blood sugars don't get below 150, the neuropathic pain will never go away. So it's the same thing with other diseases. If you don't address the disease process itself and attenuate it or abate it, then the pain will continue. Soft tissue pain, usually seen with ulcers and burns, and then intracranial pressure pain due to brain tumors, edema, and hemorrhage. I had the privilege of learning that caring for children with severe brain tumors, glioblastomas, and other types of brain tumors. Now, the rocket science of pain management is very interesting because we all have in our tip of our fingers receptors that actually will travel to certain types of dorsal horn, main plexus, and then from there they go up the spinal cord to the brain to give them information. So when you look at these dorsal root ganglion and you look at how information is received from touching something hot, from acid, or from trauma, or actually from coldness, you look at how they travel very, very quickly. And I'm going to give you just a very quick example of that. The first group of receptors, when you touch something hot, how quickly do you move your hand away from the heat? Very quickly, in milliseconds. And what happens is that the receptors that are stimulated have a very, very fancy name. Transreceptor potential vanilla 1, 2, and 3, and then the heat-activated background potassium channel receptors. Okay, what does that mean, Dr. Peralta? That means that these receptors, when you touch something hot, will send information through these dorsal root ganglion, up through the spinal cord, and into certain areas of the brain that will make you move your hand in a millisecond. They travel at anywhere from 50 to 60 meters per second. Then you have these acid-sensing receptors from afferent nerves as well. And it's very similar. The last one I want to share with you here is the dorsal root acid-sensitizing ion channel subtype. Okay? That's a fancy name for saying acid indigestion. Okay? That is when you have that bloating, that fullness feeling, when you're eating a pizza or something very spicy and you're paying for it. Okay? There's mechanical receptors as well coming through afferent airways, pathways that have a lot to do with different types of pain syndromes, and then also thermal receptors as well. And here's a quick picture of telling you from an inflammatory pain perspective how pain is modulated. So it's not just a very simple where you have acute pain or chronic pain, because there's a cascade of different substances that are released when you either have an injury in your knee, or you have gastric indigestion, or you have a rupture in the vessel, or you have a cut and you have an inflammatory process. You have all these mast cells that release a lot of different substances: histamine, serotonin, bradykinin, prostaglandins, ATP, hydrogen ions, nerve factors, nerve growth factors, tumor necrosis factors, alpha, beta, interleukins, and endotheliin. So all those are part of this pain process that we talk about trying to manage, and certainly sometimes not manage it with one single drug. Then you have the neuropathic pain. Neuropathic pain is the most difficult pain to manage. People call it phantom pain. It's a localized numbness, tingling, and burning sensation. You have dysesthesia, which we see commonly in brachial plexopathies, but also in peripheral neuropathies as well, where you have this abnormal sensation in which you have this numbness, tingling, and burning sensation. And then you have allodynia. Allodynia is a type of pain that can be thermal, mechanical, and chemical. And most common allodynia we see is touch. Here you are, you're approaching a patient, and you barely touch their arm or their leg or anywhere else. Oh, no, that hurts. That's severe pain. Stop doing that. Well, that's abnormal, okay? And that's typically what we see with allodynia, which is this particular very noxious stimuli to skin, a pain on light touch. The rocket science of all this is this peripheral type of stimulation then goes centrally due to chronic pain. And the sustained input of this peripheral neurons continues to go to certain types of neurons, which we call the inhibitory interneuron. And this inhibitory interneuron, after chronic pain, dies because of excitotoxicity. It's a very important word, excito. So constantly stimulating this particular type of neuron will actually cause the death of this neuron. We know now in Alzheimer's disease that the same excitotoxicity due to the beta amyloid proteins also causes the death of neurons in the brain and leads to eventually loss of cognitive reserve and, of course, dementia. So these cause structural changes in the brain, which therefore cause pain not to be relieved. This is an example of where some of these receptors lie at the end of a synapse. And here you mentioned here the transreceptive potential of phenyloid 1 and other receptors that we talked about. But this is probably one of the most important things I want to leave you with, okay? And this has to do with actually the end of a receptor on an organ and the 150 substances that are released when pain is realized, okay? And this inhibitory interneuron causes a negative feedback system that stops the pain. This is how it works. And this chronic toxicity or neurotoxicity of pain, if it's not relieved, this inhibitory interneuron dies and is replaced with an excitatory interneuron. And when it's replaced with this excitatory interneuron, then the pain promulgates all the time. So then it's very important to break that pain cycle so we can preserve the integrity of this inhibitory interneuron so it can do its job. We don't really think about that very often because of the fact that we say, well, okay, let me give you a typical example, okay? You're a weekend warrior. You go out to the yard and you say, oh my God, I need to do this and this. So you start on a Friday afternoon, you get all your things. Saturday you go out there, you start working on the lawn. You cut the lawn. Then you edge it. Then you need to plant certain things. And that leads into all day Saturday, part of Sunday. And by Sunday afternoon, you're exhausted. You can't move a muscle. You're tired. You go to bed, you take 2 Advil, and you wake up in the morning Monday, and you're hoping you can get up and go to work, right? Okay? You're hoping you can get up and go to work. And you make it through work. And then somehow you made it through work in the afternoon, and then Tuesday you're feeling a little bit better, and by Tuesday night you're almost back to normal, and Wednesday you're back to where you were before you started that yard work on Friday. How did that happen? And that's the miracle that we have, this mysterious way in which the body heals itself, how the brain heals itself through neuroplasticity by using these inhibitory interneurons to relieve the pain. Very, very complex process that occurs in our body. So therefore, when we talk about this neuroplastic brain, this neuroplasticity, it's a term to define how the brain literally is very plastic. We call it cortical plasticity or cortical remapping. The brain is able to remap, rewire the circuits to relieve the pain. The concept of neuroplasticity implies that certain areas of the brain are dynamically rewiring in response to changes in the environment and also challenges the notion that the brain functions are fixed in certain locations. But not only environment, but also illness and pain. This term neuroplasticity was coined by a neuroscientist by the name of Jerzy Kronowski. So the brain is capable to actually generate new neurons. We are given 100 billion neurons when we're age 2. Actually, it's very interesting. We're born with about probably 50 billion. But at age 2, we're at the top of our game. We have 100 billion neurons. Maybe that's why it's called the terrible 2. But subsequently, we have the ability, and this is one of the greatest discoveries in medicine over the recent 100 years, is the sense of neurogenesis. That is, in a certain area of the brain, the dentate gyrus, we can actually grow, and also the entorhinal nucleus, we can grow new neurons. Very, very exciting. So when we talk about neuroplasticity, we talk about the brain's ability to heal itself, okay? By that is thinking, learning, and acting actually change both in the brain, the structure, the physiology, and the anatomy of the brain. So the brain is very plastic. It will adapt, and it will try to heal itself. In most disease process, the body tells you there's something wrong. What do? We ignore it. We don't pay attention to it. And subsequently, we don't take care of ourselves. So therefore, the challenges are that the brain works in different regions and remaps the brain and rewires the brain so that actually there is a restructuring of the brain for anatomy, physiology, and remapping. Okay, what exactly are you talking about, Dr. Peralta? What is this concept that has to do? Now, we've known about the concept of neuroplasticity and pain management probably for over the last 20 to 25 years. It's coming to play more, and we have more information about that because of the fact that there's a lot of focus on looking at the anatomy and the function of the brain because of dementia and other type of neurodegenerative disorders. So subsequently, there's a lot of more information that we've learned about neuroplasticity and its effect. It's an excellent website, Luminosity, that has a lot of information regarding neuroplasticity. But basically what it says, and this is to give you an example of a disease process. Someone has a stroke, okay? They have a stroke on the right side, so it affects the left side. And so they have severe weakness, or what we call chemoparesis, loss of function in the right hand, the right arm, the right leg. They have facial type of neurological defects. And so they get physical therapy, occupational therapy, they get speech therapy to help them swallow. They have oropharyngeal dysfunction with neurogenic dysphagia. And then they slowly matriculate. Some of them get better, whether it's an ischemic stroke or whether it's a hemorrhagic stroke. Some of them don't, okay, depending on you. But as long as we exercise that weak side, the side that's been affected, we are actually helping the brain rewire itself. Because you see these people 1 or 2 years later, and they're almost 90% normal. And you say, oh my God, that great physical therapy. Oh my God, that great occupational therapy. Oh, that speech therapy. Oh, the doctor, the neurologist. No, no, no. It was the brain actually moving function from one side of the brain to the other side of the brain and compensating for the lost function secondary to that acute hemorrhagic bleed or the ischemia. So therefore, from my perspective, neuroplasticity plays a major role in pain management and hoping to understand what happens with it. Then we have neuropathic pain, which is the most difficult pain for us to manage. And that usually has to do with sodium channel inhibitors like anticonvulsants, drugs that are endogenous and very similar to really increasing pools of both serotonin and norepinephrine, and then of course the N-methyl D-aspartate ion complex receptors. So we have an opportunity for us to look at pain management from a neurobiological perspective, from a perspective of neuroplasticity, and understand why pain occurs because of the excitotoxicity of the pain if we don't break that particular pain cycle. This completes